So thank you everyone. It's a hot day today. Assalamu alaikum also, and good afternoon. I might sound a bit odd because I've got a bad flu, trying to keep away, but that's one of the hazards of working in clinical areas and also in research. And a lot of my colleagues here undergo the same problem. So my job has become a lot easier because a lot has already been talked about from a lens, a global lens, right? CHAMPS global lens. How is it helping? I'll try to take you through what we are doing in Pakistan and how it has helped us in understanding the causes of death so we can intelligently use our resources which are limited and have big impact. That's the whole idea of CHAMPS. So as clinicians, as researchers, this is what we are trying to do. I think we know now what we are looking at, and I'm really happy to hear that maternal deaths is going to be included because maternal and newborn cannot be separated. They're one and same, and they're interconnected. If you want to save mothers, we need to save newborns. If we want to save newborns, we want to prevent stillbirth, we must work on the mothers as well. Unfortunately, this has been something which has come up a bit late, but I'm very happy that it is there. And also a disclaimer that I have joined CHAMPS very recently, and it's only this year that I joined in June, but it has been a wonderful experience working with experts and with Dr. Momin, and I think the team, the field team, the Decode panel, and our collaborators deserve a good clap because this is tough work. Believe me, we all are researchers, but doing MITS is actually tough work, especially the cultural background that we belong to. So a big shout out to the entire team. So basically this is what we do, verbal autopsy. Just a bit about verbal autopsy quickly for people who are not aware of what verbal autopsy is. Verbal autopsy, as the name entails, is basically a method where we try to find out the cause of death by visiting the families who had a deceased, and we give them some time, two to 4 weeks time before we approach them, let them get through the grieving period so they're happy to discuss with us. And it is sort of an open narrative where people like to talk about their deaths. You know, mothers, they love, I wouldn't use the word love, but they do want to talk about their newborns who didn't make it. And that is a time where they share, and believe me, they remember. Every mother remembers a loss, a stillbirth loss or a newborn loss. So I think that is one important piece, that narrative. And then there are closed-ended questions which we try to take. The hospital record really helps. But even verbal autopsy and hospital records together do not really give us that confidence. That is this death due to preterm? Is this death due to say birth asphyxia or sepsis? And even seasoned clinicians are unable to sort of, tease out the two causes of death. So herein MITS come in, and I think MITS is a very valuable tool, and which really adds to the evidence, because I consider cause of death is like, you are actually evaluating a murder, and you're looking for clues. You're looking for witnesses, you're looking for clues, and you put them together, and then you sit down and try to find out what actually happened, and you tie the dots, one dot to the other, look for plausibility, and then be confident enough to make a diagnosis, which will then help us in channelizing our investment. With that, I move to the next slide. I'll skip this because you all know. This is also the same slide. So what I just want to say for this slide, every component is important. It's a teamwork, every component. Without any one of these, we probably will not have that much confidence in coming to a diagnosis. So all the components of the MITS are extremely important. So coming to the data, what we have is, these are the three sites. If you look at the box up there, let me see if I can, yeah. So these are the three sites, Ben's Colony, Ibrahim Hedri, and Akbar Goat, where we have these number of death notification. Dr. Momin has entailed in depth what we do. And the consented numbers are 386. who actually consented to be a part of the trial, a part of this entire project. And then 72 myths were collected. The number here that you see is 314, which actually did consent but did not give myths. All right, so we still have some information, that is verbal autopsy and also the medical records. The VA was collected in 65 verbal autopsy, as I told you. And so the thing about verbal autopsy is you have data collection, the data comes in, and you look at the narration, you look at the systemic questions that are asked, respiratory, cardiac, infection, birth history, and all of that. And then a physician actually tries to come to a diagnosis, and this diagnosis is based on ICD coding. Once that diagnosis is made, there are two physicians who look at the evidence and very separately, and then they try to come to a diagnosis. If the diagnosis matches based on the information they have, which is hospital records plus verbal autopsy, they may say that the baby died of birth asphyxia. If you have a condition where two physicians are giving two different versions, one is saying this is birth asphyxia, the other is saying this is prematurity, then a more experienced third physician comes into play who is blinded to the first two diagnoses and then makes a diagnosis. That's how we do verbal autopsy, and there are multiple, if people are interested, there's a lot of literature which is available on verbal autopsy, both from Pakistan and from South Asia and Africa. So then we have the clinical data in 61, and finally the decode panel. We are very happy to say we have done 50 such cases, and I'll try to take you through some of them. So some of the faces are familiar, some of them are sitting with us. Dr. Farah is sitting here, Dr. Furqan is sitting here, Dr. Zishan is here, Dr. Halima is also here. These are all code, and we have Dr. Sana here, Dr. Maria. So most of them are here. So this is a multidisciplinary team. We have histopathologists, we have pathologists, we have ID experts, we have obstetrician, both from Dr. Fareen from AKU, Professor Halima from the public sector. So we are looking from both perspectives. And we have we have Anita Hutwani and Furqan from the microbiology, pathology. We have social scientists, we have epidemiologists, Shyam Sundar. So it's, you know, it's a very rich combination. And putting all of this expertise together, we try to come to a diagnosis. This is the process. So you have the four sources of evidence, which is the microbiology lab, the histopathology, the tag tracker, the packages of VA with all its clinical records. It gets uploaded into the REDCap and then into the CHAMPS portal. And then finally, a request is generated. The field people, the doctors, they sit down together and they make a report. And then this report comes in to the weekly meeting that we have for the decode panel, which looks both at under 1 age deaths and over 1 year death. So findings very quickly. So we've looked at the global data. Let's look what we have from the 50 cases, odd cases. This is a gender distribution, all right? So the blue is male, and the purple should be pink, but purple is female. And you can see the stillbirths, they're more male, deaths, stillbirths, than female. If you look at the first 24 hours, the ratio is same. There are 4 females, 4 male. Early neonatal death, more males. Late neonatal deaths, which is around 1 week to 28 days, similar 3 in each gender. And infant is a 7 in males and 4 in females, and child death, if you look, 1 in male and 5 in females. A bit of, you know, there's this thing about whether the females actually, is there a care seeking similar to male and female? So maybe this slide can give you some ideas about that. Are we still struggling with gender inequity, or are our you know, girls, young girls or young children, female babies are coming to the healthcare provider, and when are they coming to the healthcare provider? So I'll touch that later on, but just to highlight this aspect. This is the stillbirth by age distribution. So stillbirths 24, and we saw in the global data and the multi-country CHAMPS data a similar slide. Neonatal 31, we are struggling with under 5 neonatal mortality, and we know that neonatal mortality is contributing significantly. Infant death and child death. So you can see the majority of the pie chart is being occupied by neonatal death and stillbirths. Even if we are able to bring down and cause a dent in these two, that will lead to significant reduction, and we will be able to achieve the SDGs. So now, place of death. Very interesting place of death. If you look here, 65% are hospital deaths. So it's not only access, it's when you reached, how you reached, at what time did you arrive at the health facility, what services did you get. So then comes in the concept of quality care. We know now from evidence that a lot of deaths actually in LMIC are occurring at facility. We know now that it's more institutional deliveries than community deliveries. But then comes in the quality. It's not enough that it is institutional delivery. It's important that these deliveries are conducted with standardized care and that newborns and children receive quality care. So the element of quality care is another finding that is coming through the CHAMPS data. If you look at the hospital versus hospital versus home deaths, what you see is that the blue are stillbirth, the orangish mustard is neonatal, gray is infant, and child deaths are in somewhat orange color. So basically what this slide is trying to tell us that for every age group, you do have a high rate of death in the hospital. Look at the stillbirths, and also for the neonatal deaths. So there is a significant number, and almost 50% of infant death are occurring in the hospital. So again, facility deaths is one important finding, irrespective of the age of death. The graph that you see there is a data that comes from a population-based study, the VASA study, which we looked at verbal autopsy and social autopsy across Pakistan. And this was in 2017 and 18 across Pakistan, and where we saw that the neonatal mortality was somewhere around 40, and the stillbirth was somewhere around 39. So our data is almost similar. So what we are looking here is this, that neonatal mortality is the highest mortality in both VASA and social autopsy, as well as through CHAMPS data that we have. And we believe there is, complication around the perinatal death, as mentioned by Portia, that it is basically around childbirth that things go wrong, and we are unable to pick up high-risk pregnancies, and hence the poor outcome both in the mother and the neonate. Again, I think the same situation for stillbirth and home deaths. These are the areas where we really need to look. Home deaths are around 50%, if you remember, child deaths were at home. So maybe care seeking is late, or maybe they are going, as Portia mentioned, to quacks. In Pakistan, we have a huge problem with quacks, with self-healers, and also self-medication. That is another area I think Dr. Momin can allude later when we collect the data. There's a lot of self-medication that occurs in our population, and people working in public sectors such as Dr. Nasir would know that a lot of patients would first try their best to somehow get treatment through pharmacist, and then when nothing was, then they would end up in a public sector hospital almost dying. So these are very important social, cultural factors that come out through this CHAMP data. Just want to stress on the quality of care, and I think I'm very happy to hear that CHAMPS is actually working across quality of care, because without it, no matter how many facilities we build in, no matter how many hospitals we have, no matter how much HR we have, till we don't have the quality of care that is required for that particular disease, we will not be able to save children. Stillbirth are classically divided into antepartum and intrapartum. Antepartum means that before the onset of labor, and intrapartum means that the mother did go into labor, she felt the labor pains, and then the baby died. So we divide classically into intrapartum and antepartum. Majority of the deaths across globally, and previous data also shows that the proportion of antepartum deaths is high. It's difficult to find the cause of antepartum death. Sometimes it's very sudden. You don't know, is it a maternal cause? Is it a congenital anomaly? Is it a metabolic disorder? Is it a placental pathology? So it's extremely difficult to pick antepartum deaths. However, the intrapartum deaths are the low-hanging fruits because majority of them are around the type of delivery. And these are the deaths that can be prevented if we know exactly what caused the death. Was it delay? Was it, delay in diagnosis, mismanagement, arrived late, or did not go a C-section when there was obstructed labor? So let me give you an example of a MITS case very quickly. I'll just like to tell you that this was a stillbirth. And this stillbirth, the gestational age was almost 40 weeks, gravida 7. That's another issue. And I think that also data needs to come out. It's not in these slides. The gravida of the mothers. We have been seeing in the panel go, Dr. Farah and Furqan, Dr. Furqan, they are here. Dr. Halima is here, gravida 12, gravida 14. What are we looking here? I mean, what is happening to the women? How will she be able to give a birth to a healthy newborn? She's totally malnourished, substance abuse, gravida 12. So this data is also extremely important. In some way, we should project Dr. Momin's suggestion and see what can be done across this area. Family planning is one very, it's a sore subject with Pakistan. But I think that's very important. So coming back to the case, the ultrasound was done. Now see, the data for the ultrasound was so important because it brought in two high risk, one an IUGR and a transverse lie. If we did not have this ultrasound data, it would be very difficult from verbal autopsy to be sure that this was an obstructed labor. So, and then moving on to the culture, in this particular case, unfortunately, culture and TAC was not done. But the MITS, what did it show? It showed the placental pathology, and it showed placental insufficiency. The gross morphology was also different. The placenta was small for the age, gestational age, and hence we know that something happened which was related to the placenta, okay, and that led to the death of the newborn, a stillbirth. Neonatal deaths, these were the causes of death for newborns. We had 10% of our cases died of complications of prematurity, 50% asphyxia, and 40% neonatal. Some are following the global trend. It's almost the same across. So MITS, this is a very interesting case in which there was sepsis and prematurity. And because we had the hyaline membrane disease histopathology with us, we grew bugs in this particular patient where you can see the Klebsiella pneumoniae and the Pseudomonas. So it became easier for us to put the dots together with this sort of a history. And remember, sepsis is so difficult to diagnose. Every baby who comes into a neonatal unit is called sepsis, presumed sepsis, or clinical sepsis. So when you work through these cases, if you get evidence which really points towards and tell you the etiology, you can put these complications, these presentation along with the CSF and blood culture finding and then come to a diagnosis. So we know this patient had sepsis. It was a late onset sepsis because the baby presented at 10 days of age. And the underlying cause could be prematurity because we know premature babies are at risk. Their immune system is not good, and hence this can result in them being more prone to infection. And another factor, I think, is the HIA, hospital-acquired infection, that we should all be really concerned about now, and the AMR. These are some of the immediate and underlying cause of death, and they follow the global data on pneumonia, on sepsis. Some of them are still undetermined, and just like to pick up one point here, which is failure to thrive. Can you see these 4 cases? So these were severe malnutrition. Some of them look like malabsorption, some were, failure to thrive, that they were not able to put on weight. Some of these babies were born low birth weight, and hence I think malnutrition is one of the most important underlying factor in our population, which predisposes them to a number of illnesses. And then the congenital heart disease, we were able to pick this. If we did not have the MITS, we would not be able to pick congenital malformations and congenital heart disease. And another point that we did discuss during our panel code was introduction of X-rays, radiology. which would really help us. So I think that's something we've put forward to Dr. Momin, and he's looking into it, but I thought just that would really add to the armamentarium and make things even more easier for us to come to a final diagnosis. Again, children underlying this, they are same across, but just like to tell you about this baby who had TOF. A typical history of TOF was being seen at a cardiology unit, but somehow succumbed to one of the TET spells and died of hypoxia. And we had the tissue specimen that showed severe hypoxia. So this is a classic example of how MITS has really helped us. It's very difficult. I've done lots of them, more than thousands and thousands of verbal autopsy. I would still be not sure in putting a tetralogy of Feller there if I didn't have the histopathology, and Dr. Zishan really helps us in these cases because he brings in the diagnosis that we want. And that really makes us confidence in making these diagnoses. Quickly, so we had this case where we were debating, is this aspiration pneumonia or is it something else? The history showed that the child had failure to thrive, was not gaining weight, had difficulty in breathing, was lethargic, was not digesting, and for the last 2 days, he stopped eating well. This is a child. And when we looked at, and in his presentations would look like myocarditis or dilated cardiomyopathy. Now, even the best of clinicians would say, how can you diagnose it? Give me a tropi, right? Or give me something, give me a big heart or a big liver, and then I'll say this is myocarditis. But look at the histopath. The histopath did it all. The kid did have aspiration because of the final event of his life, but his underlying condition was myocarditis. So this is what CHAMPS does. And I don't think anywhere with verbal autopsy, we would be confident in making this diagnosis. Hence, this goes into another etiology, which probably did not exist in verbal autopsy. So that's how MITS helps us. You can see sepsis is always there across all stillbirths, chorioamnionitis in the mother, neonates, culture. So again, very important. Culture-proven sepsis. I know people who work in the public sector, it's very difficult, for them to hold back antibiotics or not to escalate antibiotics because they don't have an antibiogram. They don't have cultures available with them. So see, in these patients, majority of the patients, we had culture-proven sepsis. So sepsis is another challenge that we face in terms of etiology across all age groups. Respiratory distress syndrome, 8 cases, most of them were premature babies and died because of respiratory distress syndrome, hyaline membrane disease we got in the histopathology, and the findings were suggestive of respiratory illness. So now, were these deaths avertible? That's the question, right? And that's what we are doing here. Yes, majority of the deaths were avertible. One of the components of CHAMPS is we get to be asked, could you have done something different? Could you have saved this baby? Professor Halima gets to be asked, could this not be a stillbirth? And she would say, yes, if 1, 2, 3 happened. And all of those things are no rocket science. They don't require a huge amount of money. They require capacity building, HR, infrastructure, and awareness, advocacy, awareness, standard case management, accountability. That's what's going to change the way, how we work and will help us in, bringing down the under 5 mortality. So most of these cases, we had a consensus across the panel that these are preventable deaths. And they are across all age groups. It's not only neonates and stillbirths. We can save infants, we can save child. We just need to know what is the cause of death and how can we improve the care-seeking behavior and quality of care. And you've seen some of these labels, but these are some of the CHAMPS collaboration. And I would just say I'm a clinician by heart and a clinician researcher. I do both, but the closest thing is neonates to my heart. So when Momin told me that, Shabina, would you be interested? I said, yes, I would be interested because this is so important work and we only get one lifetime. So I believe to make the best of this lifetime when we are young, I still consider myself young and try to do the best within us. So thank you so much for your patience and for listening to me. And thank you again for the entire CHAMPS team for giving me an opportunity to present this.